So nice to see everybody. The goal was to be there today. And then my wife actually ended up going down to UPenn last minute to do some IR research stuff. So for childcare purposes, here I am. But I'm sad to miss you all in person. Okay, I will make this brief, right? It's supposed to be around 10 minutes. So I will make this very short. Those are just disclosures. All right, so highlights. I think we all know this, but it's pretty staggering what's going on within really the global population, but if you look within the US in particular. So this looks at the number of people, so millions of people 65 years and older. So if you look in 2016, it was about 49 million people. Fast forward to 2040, 2050, almost double, 85 million people. And actually the percentage of the population is increasing. So around 22% is 65 years and older. Interestingly, when you look at IBD, it mirrors the same exact epidemiologic transition that's occurring. So if you look, this was a nice paper by Kappelman and Jim Lewis that recently came out. But if you look at the overall prevalence of IBD in the US, starting at around age 40, about 1% of the entire IBD or the entire population has inflammatory bowel disease. So what does that mean? If you're seeing someone 60 years old, you line up 100 of them, one of them is going to have inflammatory bowel disease. So that's pretty staggering. That's, again, starting at around 40 years of age. This, on the other hand, is what's going on with the number of geriatricians. So this is the number of geriatricians, over 10,000 population, 75 years and older. So you can see that this number is just declining very rapidly. So we have very few geriatricians now. And the problem is, as you can see, the population is aging. This is again happening within the IBD patient population. And there's this huge gap, right? So whether it's IBD, whether it's functional GI, whether it's cirrhosis and liver disease, we are going to be all seeing in our clinic an aging population. And there's gonna be fewer and fewer geriatricians, there's fewer primary care physicians. And so as a whole, we are gonna be primarily managing these patients. Now, why are we even talking about them particularly? What's the nuance with older adults? Well, there are special considerations for a couple of different reasons. One, they already have an ongoing inflammatory process. So John Fred and I actually wrote an editorial or a review a couple years ago now, but this whole idea that aging itself is a sterile inflammatory process, you couple that with IBD, which is an inflammatory process, and you get this idea that perhaps there's really an advanced biological aging. So our patients may actually be rapidly accumulating diseases and comorbidities we see in older adults at a much earlier age. So we see that. They have more comorbidities. I just saw a patient on Friday with cirrhosis, COPD, MAC. She also had ischemic cardiomyopathy and severe ileal Crohn's disease, losing weight. What do? Those are complicated questions, right? This is someone who is not your healthy 30-year-old where you can reach for TNF or JAK inhibitor, and we can't even get them into clinical trials, right? TL1As or TYK2s, these patients are going to be excluded. So it's very challenging. They're also at a higher risk for social isolation, physical and cognitive limitations. They're at a higher risk for undertreatment, right? We're afraid to do anything and to cause any adverse outcomes. So we have a prescription and a surgical hesitancy. They're at risk for polypharmacy, which I'll talk about, and that in some puts them at risk for adverse events. But one of the key things about why it's so important to be thinking about older adults and to actually be thinking about them almost on a more rapid timeline than our younger adults is they don't bounce back, right? So you may have a very short window where you can really control this inflammation and get them on a trajectory that sends them to a good clinical outcome, as opposed to allowing the inflammation to go on for a period of time, which we'll talk about, and then they progress towards frailty. And then it's very quickly the wheels come off, right? So these are patients that we want to be very cognizant about how quickly they can actually deteriorate in our clinical decisions and how timely clinical decisions can actually improve outcomes. And this is kind of like something in the geriatrics world that even during training really struck me. And the general rule of thumb is for older adults, 1 day in the hospital takes them a week to recover. So just think about that. We want to avoid hospitalization, but just the idea of how long it takes to even bounce back if you can get back to that baseline, right? So a 30 and 40-year-old, they are likely to get back to that baseline. But someone who's 60, 70, 80 years old, they're much less likely. And you can quickly see how things can deteriorate rather rapidly. All right, so I think I went through a similar case a while ago, but I will again put this in the context of the 5 M's of geriatric care, and I'll talk about some of the data we've been doing. But this was a patient I saw, so 74, moderate ulcerative colitis, several weeks of corticosteroids. So one of the M's we think about is like cognition, sleep, fatigue, right? So corticosteroids give a host of bad problems, but particularly in older adults, it drives a higher risk of adverse outcomes compared to younger adults. So there is true, ongoing inflammation may require a continual or repeated course of corticosteroids, but short courses are sometimes needed and helpful, but you really need to not use long courses in older adults. We see it time and time again. I think it has to do with this, again, prescription hesitancy, surgical hesitancy, the ease of corticosteroids, but it comes with a host of problems. So reduced quality of sleep, anxiety, mood disturbances, and then a whole host of comorbidities. And again, there's data to show that older adults actually have a higher risk of adverse outcomes as a result of corticosteroids as compared to the younger adults. And then again, it does increase the risk of infection. So I think we don't want to prescribe anti-TNF or JAK inhibitors. We're concerned about infection, but we actually forget that corticosteroids may be one of the most potent drivers of infections in this population. Okay, so they started on mesalamine with some improvement. This was a question I've had, and it's a retrospective look, so obviously there's some biases by indication, but essentially what we looked at was, what if we achieve mild endoscopic disease versus remission in older adults? Does it actually matter? And what we found is at least within 1 year of follow-up, if you have mild ongoing disease, you are at a higher risk for an adverse outcome, about twice as likely. And if you look at IBD specific adverse outcomes, so hospitalization, corticosteroid use, it's about 4 times as likely. So the mild disease, 16% required it at 1 year, as opposed to 4% among those in remission. So you can see that even, and there's nuances here, but as a whole, aiming for endoscopic remission may even have added benefit in this patient population. This question is getting to mild endoscopic disease enough in older adults, and at least, again, retrospective, so biases, baked within, but there does seem to be some benefit there. So what happens next? They increases the mesalamines, they added enemas. So we do this often, but something you have to consider is, can they actually administer rectal treatment? So I have plenty of patients who have cataracts, who have glaucoma, who have macular degeneration, who need to see ophthalmology. They have a very hard time doing rectal therapy. Also, what about urgency, right? So we think about urgency, but how does it relate to their morbidity and clinical outcomes? So this is how I think about urgency and sarcopenia. So what happens? Again, older adults are not going to bounce back quite as well, right? So what happens? They have urgency and incontinence. We leave them for a while. What does that do? It leads to physical inactivity. They don't want to go out, right? They sit by the bathroom. They're not going out and spending time in the outside world. They also aren't sleep. They're not sleeping well. They have fatigue. What does that do? Well, it leads to further physical inactivity, right? During the day, they're too tired to go out. What does that do? Well, it leads to muscle loss. So you start to develop sarcopenia. What happens when you have sarcopenia? Well, maybe they have ongoing inflammation as well. So they're getting more prednisone. That leads to worsening muscle loss. Muscle loss, again, leads to more physical inactivity. So you're starting to see the cycle in the picture here. What happens from that? Well, if they're not getting up, again, these are not your 30-year-olds. They're probably still going to work and moving around. These are patients who are 60, 70, who may already have some physical limitations and are now essentially homebound. They have atelectasis. What do? They get infections like pneumonia. They're not moving around. They have ongoing inflammation needing steroids. They can get a VTE or a MACE event. They're not cognitively engaging in the world. You can see a much faster cognitive decline. And in a population of patients we've been following prospectively, you can see some actual cognitive deficits. They're at increased risk for falls. If they have falls, they're at increased risk for an osteoporotic fracture, right, from prednisone. Social isolation, depression, and then that leads to hospitalization, mortality. And again, you can kind of quickly see how the wheels come off here. Also with muscle loss, we looked at this, and muscle loss is also associated, there's been a couple of other studies, but adverse postoperative outcomes. So there's been an increasing interest in myelostenosis, sarcopenia. I'm not going to get too far into the weeds with this, but we looked at a couple different ways to assess, and muscle loss increases the risk of an adverse 30-day postoperative outcome. So again, you can see how even urgency and not really intervening in a timely fashion can actually have pretty high consequences in terms of clinical outcomes. So what happens? This patient then is now on 4 pills a day. They're getting rectal therapy as well. So you need to think about polypharmacy. So we looked at this and published this in AJG, where you can really see a nice separation. The more polypharmacy, the higher risk of hospitalization. And it makes sense, right? If someone has 7 or 8 medications and you're asking them to take 4 of one, I mean, I don't remember half the time whether I took a multivitamin today, let alone whether I took all of my 8 pill bottles or whether I took 4 of this one, or did I accidentally take 4 of my antihypertensives? What happens when you take 4 of your antihypertensives? Well, you probably land yourself in the emergency room. So what happens? Again, mesalamine's not working. Now, this is a year later, so this is someone with much more severe disease. They start an IL-23. You have to think about this. Can they self-inject? Do they have osteoarthritis? A lot of our 60 and 70-year-olds, it's very hard for them to inject at home. If not, do they have social support? Also, what matters most, think about their quality of life, again, their physical, cognitive, and social aspects of all this. And then also, what matters most, I think, is particularly important in the older adult population, because if you think about some of the things like urgency, your 30, your 20-year-olds, they're going to be out into the world, but something like in a 60 or 70-year-old, it's not just about their quality of right there, but it's also, again, making sure their physical and cognitive functioning doesn't decline over time. So it's really important to understand how some of the symptomatology is actually impacting them and what matters to them. So this patient actually starts on an infusion of IL-23, more rectal bleeding, 50-pound weight loss. And this is kind of this idea of what's going on. So this window of opportunity in older adults is actually pretty short, or at least condensed in the time period. So what happens is, if you adequately treat inflammation, there's this hypothesis, and there's some data to back this up, that essentially you can mitigate their frailty trajectory, and you can send them down this green path here. But what happens is, by giving intermittent prednisone, by leaving them with urgency, by driving them towards malnutrition and sarcopenia, what happens is, by the time you're now thinking about an anti-TNF, a JAK, a surgery, other interventions, they're essentially frail. And the problem is, once they're frail, they're at a very high risk to have an adverse outcome. And so then they get hospitalized, have a severe adverse event, and die. And what it kind of feeds back is that perhaps we should be, again, not treating our older adults with TNFs, JAK, surgery. But what it really should be feeding back is that, had we thought about this on a more condensed timeline and really operated within this window of opportunity that we think about, in Crohn's disease and so forth, we probably could have had a much better downstream outcome in terms of clinical outcomes for this patient population. And there's a couple of different studies. I just highlighted one that Bharti did here, but essentially this was of all ages, 1,200 patients with IBD, and it showed that those who had ongoing inflammation, if you responded to the therapy, only 7% were frail at the end of the year. If you didn't respond to the therapy, 27% were frail at the end of the year. So it essentially just reinforces this idea that controlling inflammation can actually mitigate or even prevent the development of frailty. And again, this happens on a much more accelerated timeline in older adults who do not bounce back quite as quickly. So what happens after the IL-23 gets started on vedolizumab? Again, you can kind of sense what's going on here. So this patient is now quite sick, but this has been going on for 2 years, right? Had we done something different in management, perhaps we hadn't started with intermittent courses of steroids and mesalamines for over a year and then started on an IL-23, but maybe we started with an IL-23 up front, or even an anti-TNF. If the disease was severe enough, we could have likely prevented these downstream consequences. So 2 months later, I meet the patient with acute severe UC, hospitalization, CRP of 100, albumin of 1.9, and then ultimately died maybe about a month or so after this. So quick take-home points. I know that was rather quick. I was just rushing through to try to make it within a few minutes, but the IBD patient population is rapidly aging. The key is our management decisions can have a significant impact not only on the quality of life for these patients, but also on the clinical course. Earlier treatment, again, adequately targeting inflammation, yes, it can improve outcomes in all adults with IBD, and this should be our gold standard. But in older adults, it actually may be even more important to do this within a timely fashion. Ongoing inflammation is a major driver of clinical outcomes. Again, in all patients with IBD, but particularly in our older adults who are very prone to small insults causing that downward trajectory towards frailty. You need to think about the risks of undertreatment. I think often we focus on TNF surgery, JAK, our advanced therapies, we talk about infectious risk, we talk about mortality, but what about the risk of undertreatment, right? So the ongoing inflammation itself is a significant driver of adverse outcomes, as is intermittent corticosteroid use. So we need to think about kind of the converse of what we're doing. Corticosteroids, I think we forget, but they're associated with the highest risk of adverse events. Obviously, I'm in good company in this group, but I think that needs to be ever present on our mind. And I'll leave you with two quotes. One, to care for those who once cared for us is one of the highest honors, but with great power comes great responsibility. And I'll pause there.
Very nice.